Good evening, everyone. So, first of all, I'd like to thank Dr. Sharma for his kind invitation. I'm expected to speak as a clinician to people regarding the problem where the solution is not in medicine, but solution is in technology and with you people. So, I'm a cardiac electrophysiologist. I take care of heart rhythm disorders. Most of my time goes into OPD, cath lab and taking rounds. But I can take care of patients who come to me. But many issues, and one such issue is sudden cardiac death in apparently healthy individuals. They don't come to doctor because they don't have any need to go to doctor. And they are normal, healthy individuals who die suddenly while in marriage, in school, in colleges, while playing football. So we are going to address this situation because I think that there is immense potential for technology to help these young individuals who are at risk of sudden cardiac death. So, can I go back to first one? So, sudden cardiac arrest is a mechanical cessation of cardiac activity, which leads to hemodynamic collapse, and if the patient is not defibrillated immediately or CPR is not initiated, patient dies, and the time duration from the cardiac arrest event to death can be just 10 minutes. Sudden cardiac arrest usually happens because of the irregular chaotic rhythm in the ventricles, that is the lower chamber of the heart, and this requires an immediate attention. Almost 1/4 of the death that happens are sudden in nature, and majority of them are because of cardiac reasons. Almost more than 50% of this sudden cardiac death is related to rhythm abnormalities, either from the previous heart attack or some muscle disorders leading to cardiac dysfunction. These are some of the data coming from our country, India. We have huge population, but somehow the data coming out for sudden cardiac death is very small, and almost 5 studies addressing this epidemiology of sudden death in last 15 years. But all of the studies tells single thing, that we as a population are at extremely high risk of sudden cardiac death. We have sudden cardiac death amongst individuals who are 5 to 10 years younger than the Western counterparts. Majority of them are undiagnosed or have no diagnosis, prior cardiac history. 2026 AIMS ICMR, which is the recent most study, shows that 50% of sudden death in Indian population is between 18 to 45 age group. So there are 5 studies, 15 years, and same message, that SCD in India is younger, commoner, and less understood than we have been willing to admit. This is a very important slide. If you look at this slide, what we are dealing as a clinician are patients. So patients who had previous heart attack, who had rhythm abnormalities in past, or who had succumbed to cardiac arrest and has survived and come to us. We risk stratify these patients, we do some intervention, implant defibrillators if the risk of sudden cardiac death is high, and these patients' sudden cardiac death is lowered. But remember, though these patients have the highest incidence or highest risk of sudden cardiac death, they contribute very less number in the society, because the denominator of the general population, normal healthy individuals, apparently healthy individual, is huge. So even though the individual risk is low in general population, the largest number or large burden of sudden cardiac death comes from the general population. And that is the problem, that is the paradox, that medicine cannot reach to these patients. These are not going to come to the hospital. And that is why it is a problem of society, policy and technology, which probably can reach to these individuals who are at risk of sudden cardiac death. Two most important interventions that have been useful in improving survival of patients who have developed sudden cardiac arrest is CPR, bystander CPR, and AED use. AED stands for Automated Electrical Defibrillator. CPR training, the one single intervention, has led to reduction in sudden cardiac death significantly in countries like Denmark, where it is mandatory to teach CPR in school-going kids. In Norway, CPR in school is there since 1961, and bystander CPR rate is 70%. So imagine if a person is collapsing, there are 70% chances that CPR is going to be instituted. In India, bystander CPR rate is 1.9% to 9.8% in few studies. AHA recommendation is 62%. And WHO has recommended that 2 hours per year CPR for all children more than 12 years of age should be taught in the school. So it has to be mandatory. Public access AED is again a very important intervention to prevent sudden cardiac arrest in society. Japan has 6 lakh plus public AEDs. Survival and neuro outcomes have improved. Stockholm, where AED is widespread access, outside hospital cardiac arrest survival has reached 70%. So if you are succumbing to cardiac arrest, your chances of surviving is 70%, which is less than 10% in our country, because there is no law mandating AED in any public space. So the areas where there is large population gathering like airports, stations, schools, gyms, place of worship should have AED installed. Now, how is it possible, how can we use technology to meet these two needs? And one is the AI bystander dispatch app, that is AI first responder applications. And these applications is not a new concept, it's already built, it's working in other areas. Good SAM Instant Help, Pulse Point app, these apps, what they do, they alert trained CPR volunteers within 500 meters of cardiac arrest in real time. So if everyone is trained for CPR in school, all of them can be volunteer, right? And if they are in that app gives notification to the volunteer who is CPR trained within 500 meters of the cardiac arrest. Copenhagen trial was done, and that showed that dispatched bystander from this app arrived before ambulance in almost 62% of cases. So before even ambulance could reach, there was a bystander, there was a first responder who could come and do CPR, and probably patient could reach to hospital for definitive treatment. In India, there is an opportunity of app-based bystander networks. If we can build app for food delivery, why not? This is again a very important use case of these kind of apps. First responder database is humongous in India. So we have a lot of doctors, medical students, nurses, paramedics registered, and GPS, and they can be used for this purpose. Drone delivered AEDs. If AEDs cannot be installed everywhere, Sweden NEJM study was published in 2023, where drone delivered AED reached in 5 minutes 21 seconds while ambulance took 22 minutes. And this is the important time frame because delay of more than 10 minutes is going to create fatal outcome. Survival doubled in drone served areas in Swedish randomized trial. And drone AED programs now live in Sweden, Canada, Ireland and parts of USA. India has again an opportunity. DGCA drone corridors in metros are existing. Framework exists. Implementation is what is required. Cost per life saved is comparable to existing emergency infrastructure investment. So this is how an integrated vision of connected emergency system looks like. So we have a smartwatch detectable or any wearable detected abnormal rhythm. AI confirms that this rhythm is dangerous. App alerts nearest trained bystander. Drone dispatches AED. Ambulance is en route till the time CPR and AED is used to regain the rhythm of the patient, and the hospital is meanwhile being prepared for arrival of the patient. So with this integrated system, bystander CPR can be achieved within 2 minutes, AED delivery can be done in 5 to 6 minutes, hospital preparation is ongoing simultaneously, and this is not something unachievable. It is already functioning in other part of the world, certain countries. So this can be done and this can be in reach very well. We have to find solutions according to our society and our logistics. So what India needs to connect the dots, we should have a nation first responder app, DGCA drone AED corridors, and unified cardiac emergency number. But most important than that is at least everyone should be trained in CPR, and AED is very easy to use. It directs how to apply, it tells you what to do, it detects the rhythm if it is requiring shock, and it delivers a shock spontaneously. So this is what the future of resuscitation looks like, and that gives an opportunity to person who had a sudden cardiac arrest to reach to the hospital, find out the reason why the sudden cardiac arrest was there, and treat accordingly. There are certain other structural interventions beyond technology which is very important for reducing the sudden cardiac arrest burden in our young population. Number one, we should have a national sudden cardiac death registry. If we haven't measured our problem, we can't tackle it. So the first thing is to have a registry. There is no national registry, and there are registries data which leads to policy change, which have led to policy change in other countries like US, Denmark and Japan. So second thing is, any patient who has died younger and who have not had any past history of cardiac illness, they should mandatorily go and undergo an autopsy, which is not again a practice in our country. So young SCD, structured autopsy and molecular genetic testing should be done. And one of the North India West study showed that 42.8% of unexplained sudden cardiac death could be diagnosed by just an autopsy and molecular genetics. And imagine if somebody is diagnosed with a genetic arrhythmia, and if you have detected it in autopsy molecular genetics, you can survive, you can probably increase the survival probability of their kins and their family, because they are also going to have higher risk of sudden cardiac arrest. So screening of any individual who has died suddenly, screening of family members of individual who has died suddenly is again very important step. Pre-participation screening, this is the least we can do. Person who is joining gym should have at least a self-declaration form and 12 lead ECG screening before engaging into a severe heavy exertion. Many times the cardiomyopathies are occult, they have not produced any symptoms, they have some channel disorders which is going to put them at risk when they do vigorous training. So in Italy 1982, ECG for all competitive athletes was made mandatory, and that resulted into 89% reduction of athletes' sudden cardiac death in coming 25 years. India should again adopt it. Gym, school, sports federation, the mandate of at least a screening ECGs. One single ECG can make a lot of difference. So, sudden cardiac death in young individual is not unforeseeable. It is under reach. Medicine will always arrive too late for the person who collapsed without warning in a public space. So medicine cannot reach immediately, but technology, if deployed thoughtfully, at scale, guided by good policy, can be there first. So that is the challenge I leave with this room. Dr. Sharma has told me that there are so many bright students. He had seen you participating in the competition yesterday, and this is the challenge that I leave with this room. Thank you.